very much for tuning in, as always. I want to say a big thanks to Josh Channon, who came on last week. We had our first in a couple of years, in-house interview, but it was the first that was on camera. So we stuck with the camera that we used, the webcam that we use. I think it worked okay. I mean, myself and Josh, it was about basically, myself and Josh have very different opinions on big and small things, but we talked about the importance of not letting these things get in the way of like being friends and stuff. And I think it's kind of a message that can carry on through to family and all those things. So it was really, it was a lot of fun. And, thanks for your support during the week with all the shares and the likes and all that stuff that you always do. We really appreciate it. We'll get into this week's episode. This week's guest is a professor of psychiatry at Trinity College and the author of In Search of Madness, a psychiatrist traveled through the history of mental illness. Brendan Kelly, how are you doing?
I'm doing fine. Thank you very much for having me here today. I appreciate it. No,
absolutely. Love it. It's one that we've had coming for a while, because I know I got contact with you while you were in the middle of, I guess, of semester and things like that. So I've been really looking forward to it. But as we will discover, Brendan, it has given me the chance to read your books. So that's the plus side of it. We always start with the same question, Brendan. Could you give us a short history of your upbringing, please?
Well, my name is Brendan Kelly. I was born and grew up in Galway in the west of Ireland. I went to primary and secondary school and university there. So I'm a Galway person through and through. And I came to live in Dublin some time ago and to work in psychiatry. In secondary school in St. Joseph's College, the Bish in Galway, I wanted to be either an economist or a psychiatrist.
Okay.
So two very different and specific things. It made no sense at all to my career guidance counselor or teacher who I think despaired of me from time to time. But in the end, I became a psychiatrist, which is a medical doctor who specializes in the treatment of mental illness. And that's what I am now.
Brilliant. Thanks very much for that description as well, because I think I was probably going to bring it up at some point, but some people find it difficult to differentiate a psychiatrist to a psychologist. And, it's kind of, we did have a psychologist on who explained that. So it's nice to get from the horse's mouth, I guess, is the expression. So when did you first become aware of mental health?
Well, that's hard to know, really. I guess at some point in my secondary schooling, I noted that maybe there were some people had issues or some people had problems, or I didn't know quite the words. And I remember reading an article in a local newspaper about schizophrenia, and I had only the faintest idea what it was. The article didn't enlighten me hugely, but it did alert me that there was something here. And I guess I just became more interested. I started reading a bit about this in secondary school. And then when I was deciding what to do after my leaving cert, I was pretty clear that if I went into medicine, I wanted to go into psychiatry, treatment of mental illness, to sort of put it at its most medical for a moment. That's what I wanted to go into. So at some point during secondary school, I decided this was an issue and something I wanted to get into.
Yeah, because like even when I think of maybe back to my secondary school days, maybe 14 or 15, quite a heavy, profession to kind of think about. And if you wanted to go into the medical field, I guess, why psychiatry?
Well, that's a really good question. And, when I went into studying medicine, I realized psychiatry was different to other parts of medicine. It was quite different, say, to obstetrics or surgery or, eye surgery and things like this. Because in psychiatry, diagnosing mental illness is so different. We don't have blood tests. We don't have scans that help particularly much. It's all about symptoms, and it all changes. It seems more negotiable. It seems less certain. And yet with that, the suffering is undeniable and real, if you know what I mean. Yeah. There seem to be so many more unanswered questions in psychiatry than there were in other areas of medicine. And the idea of vast unanswered questions, it either excites you and interests you, or it puts you off and you move towards certainty, things that are clearer. For me, the unanswered questions, the discussions, the disputes, the uncertainties about all of this area attracted me, no doubt about it. I just love that. And I know even the terminology I'm using now, things like diagnosis and mental illness and medicine, even those very basic things, some people listening will think, no, that's the wrong terminology, that doesn't apply to me, that's not right. So that's why psychiatry, because the unanswered questions are so vast.
I guess that's why, I found, we'll be talking about 2 of your 3 books that I've read, but we'll be talking about psychiatry in general, but also about mental health and mental illness, which you highlight in your book as well, because there's a big difference. And I think a lot of people aren't quite there yet with, the terminology of either side. When I read Hearing Voices, that's you're the book that I didn't mention, Hearing Voices, The History of Psychiatry in Ireland. I said to you just before we came on, it was very readable. Even though you pick up a cover and you see a title like that, you think that's going to be heavy going. But then you read it and you think, how much work did you have to put in? Because the notes section is nearly as big as the actual book section.
Yeah, so Hearing Voices, The History of Psychiatry in Ireland is a book I wrote. It came out in 2016, I think, from Irish Academic Press. And I wrote that because there was no single history of psychiatry in Ireland that tried, perhaps foolishly, to tell the entire story from the start to the present day. So I thought that the field needed such a book. I thought such a book is maybe impossible to write fully and correctly. But again, the idea of big unanswered questions, impossible tasks, draws me like a moth to a flame. And I decided that I would do this. And the book came out in 2016. So it's a detailed book. I've made the story as readable as I could manage. It took a good amount of work, but I loved every minute of it. And I think everyone knows that, when you like what you're doing or you're fascinated by it, it takes a lot of time, a lot of effort, but it kind of stops being work in the sense of work being something difficult or unpleasant. So yeah, it's quite a detailed book. It's a long book, but it tries to tell the story of psychiatry, and particularly how we ended up where we are today, with all its strengths and imperfections, to put it mildly, based on where we've come from in the past. So it wasn't that much work.
Good, because I learned a lot from it. I learned about Asylums back, many, many years ago. And you talk about Asylums as a medical and social creation. And I think the medical one, I guess, speaks for itself, but I didn't quite understand. Well, I guess I did now after reading it, but could you describe what you meant by a social creation?
Well, when you look at the history of mental illness, or people who were, so-called lunatics or had so-called madness, which are terms I'll use, Derek, from time to time, but without meaning they should be used today. I use these terms talking about history only. When you look at this, you find that up until the 1800s, people with lunacy, as it were, tended to be homeless or in prison or to die young. So society at the time, the governments decided to build these enormous psychiatric hospitals. And we did an awful lot of this in Ireland. And a lot of people will be familiar with the hospital near their town, be it in Ballinasloe or in Escorthy or, all over the place. And these huge institutions, once you build them, they're immediately full. They're full of people. And when these psychiatric hospitals opened in the 1800s, initially you did not need a medical certificate to be admitted. It was decided by the board of governors rather than the doctors, and they were immediately full. So communities and towns used these institutions in very social ways. So to give a few examples of this, there was a phenomenon called wintering in. And what that was a family might have a family member who had maybe mental illness, maybe intellectual disability, maybe they were just, eccentric and strange and a bit awkward. And that person would be put into the local mental hospital at the start of winter, left there for the winter and maybe the spring, taken out in summer to work on the farm, you know, in the autumn especially, and then put back into the asylum for the winter. So this was wintering in, and people were coming and going like this without any particular medical reasons to come or go, you know. So when I say these were social institutions, there is that. There's also the fact that these were huge. When you think of the town of Ballinasloe, for example, in the early 1900s, the town had a population of 5,600 people. And of that 5,600 people, 2,100 were patients in St. Bridget's, the so-called mental hospital. So when nearly half the town is in the hospital, the other half of the town either works in it, they supply it, or very often farms would have a patient come out from the asylum, work on the farm during the day, and then go back in the evening. So these were really integrated into their communities, and were therefore as much social creations as they were sort of medical ones. And that's really important when you look back at the history of psychiatric hospitals in Ireland, that they were used by communities in very, very subtle ways, and ways that sound, you know, really bad to us today.
It's interesting you mentioned about the words you use, because obviously there were the words back in the day and things like that. And I had I myself had mental health problems back in, maybe it was about 12 years ago when it started. And somebody just said I had gone loony. So they used the phrase loony, which was at the time was kind of hurtful. Now it's, you know, not too bothersome now. But when you talk about, they were actually called lunatic asylums, which I guess when we use those words now, if you call someone lunatic, it'd be quite an offensive term to use. But then it was the term for one of the asylums. And it's just interesting how the words and the language seems to carry over from back then, you know.
Yeah, I mean, the language changes all the time. And what happens is every generation's language becomes stigmatized, and then it has to change again. So at the time, lunatic was considered a very enlightened term and less stigmatizing than what might have come before it. But then with time, that term became stigmatized and is no longer appropriate for use, although it lingers. So as you say, it can linger as a sort of a dismissal or even an insult, to be honest, you know, a very, very derogatory term. But the language changes because we always stigmatize people, wrongly stigmatize people with mental health problems, psychological problems, mental illness, because I think everyone's a little bit worried that maybe they themselves could develop similar problems. So we use language to distance people, to distance us from the anxieties, distance us from the fears. And this has a really negative effect. This results in exclusion. It results in us not devoting proper resource to support people who need support. So the constant stigmatization changes the language, but it does an awful lot more damage than that too.
For sure. And another place I had no awareness of, there's a lot of those, but for this conversation, we'll talk about the Richmond War Hospital, because this, obviously, I hadn't mentioned it, but their kind of forward-looking treatment was fascinating to me.
Yeah, so the Richmond Asylum was also known as Grange Gorman, later St. Brendan's Hospital at Grange Gorman in Dublin, and it was Ireland's biggest and one of its earliest psychiatric hospitals or lunatic asylums. And then at the end of World War I, between 1916 and 1919, it operated a small enough shell shock hospital for soldiers, mainly young Irishmen who served in the British Army during World War I and came back traumatized. And these young men were admitted to this unit in Grange Gorman in the Richmond Asylum, and it became known as the Richmond War Hospital. And the Richmond War Hospital was very interesting because it was the first time that people were admitted for psychiatric care or psychological treatment, but were not certified as being insane. And this was a really big step forward in terms of stigma. And, you know, this changed psychiatry and the hospitals a great deal, because it proved that even healthy young men, if you like, the strongest young men who went off to fight, could be psychologically traumatized by what they saw. This was new. This was a relatively new concept. I suppose people always knew it happened, but this was official recognition. And that brought about a lot of changes. The idea that psychological suffering wasn't inevitable, that it could happen to someone who would otherwise have been okay had they not been exposed to trauma, to the war. This was a profound moment for psychiatry. And also the treatments were very gentle. There was something called veranda treatment, which involved sitting on the veranda, which, to be honest, it sounds great. And I wouldn't mind some of that now. But yes, the Richmond War Hospital operated 1916 to 1919, and it brought a lot of changes to how we view psychological suffering.
Yeah, it's fascinating to find out about that. There was obviously, you talked about the famine. Because of, I suppose, the huge implications it had on mental health. Just how much did it attribute to, the mental health problems in Ireland and maybe the people going into the asylums at the time?
Yes, well, the asylums were being built during the 1800s. So they were being built during the famine years, for example. So if you have a famine on the one hand, and people building large institutions that offered shelter, bed, and food, of course, the institutions are going to be filled.
Yeah.
And the rates of certifying lunatics just skyrocketed during the famine. This makes it really difficult to figure out just how much, real mental illness there was there, because there was a big incentive to be certified insane during the famine. So anyway, the rates of certification went up and the institutions grew, and they continued to grow after the famine. What is very interesting, though, is that about 20 years after the famine ended, we find that young people who would have been born during the famine, in other words, their mothers might have experienced starvation or illness while pregnant, those children, when they reached the early 20s, they had a very increased rate of admission to asylums. So probably an increased rate of mental illness as a result of, if you like, the stresses and the physical deprivation that their mothers went through during the famine while they were pregnant with these people. And research from other famines supports this a lot, that having a very difficult environment, in the womb, and I mean very, very difficult, like I mean starvation. So it's like people listening don't need to be that worried about some stress during pregnancy, which is now, I'm talking about almost starving to death and then having an infectious illness that almost kills you, that this does appear to have an impact when the baby is born and grows up in terms of increasing the risk of mental illness. So the famine had a big impact, both biologically and also socially, by filling up the institutions.
There's never a good time to introduce an advert in a serious conversation, but we're going to do it now, Brendan, if that's okay. So just give me 20 seconds as I try to get through this. 120 episodes, still haven't learned a word of it. Unbelievable. Okay. Fusion Training Centre, Monksland, Athlone. A place to train in Brazilian Jiu-Jitsu, kickboxing, martial arts and CrossFit. A great atmosphere with experienced coaches and a real sense of community. If you want to join the team, find us on Facebook at Fusion Training Centre or drop in for a chat. Fusion Training Centre, train like a warrior. I also want to mention that I have been coaching some women's self-defense and jiu-jitsu classes. That's into its 5th or 6th week now, depending on when this comes out. And pop in if you fancy, doing a bit of exercise and trying something different. It's all good fun. So Brendan, your new book, In Search of Madness, what made you want to write it?
Well, having written a history of psychiatry in Ireland, I wanted to bring in, what it's like being a psychiatrist today. I work seeing patients every day, seeing people with depression, bipolar disorder, schizophrenia, people who are just troubled sometimes, people who've tried to harm themselves. So I see a lot of this. And in my day-to-day work, I hear echoes of, say, patient stories I've read in the history, or I can feel some of the pressures that were felt in the history of psychiatry. Like there's a constant pressure now to admit people to hospital, to inpatient psychiatric care. And when I come under this kind of pressure, I can understand why the mental hospitals, as they were called, grew so big. We have a huge appetite for institutions in Ireland, and that's not gone away. So Yeah, so I wanted, with the new book, I wanted to link the history of psychiatry around the world, indeed, with what it's like today, to be treating people with mental illness or trying to help people sort out their problems.
I wanted to ask you, because this is something that came up in the book, and it's also something that people have mentioned on episodes here before about approaching the correct treatment for each patient, and I think a lot of people, well, maybe not a lot of people, but some people are worried about just throwing medication at the problem. And I think you made quite clear in your book that that's not what you want to do. But what do you think of that kind of the difficulty, I guess, of approaching the correct treatment?
Yeah, I mean, this is a real challenge. Overall, when you look at rates of prescribing psychiatric medication, they vary hugely around the world, like enormously, with high rates in the United States and certain other countries and relatively low rates elsewhere. Here in Ireland, we're relatively low users of psychiatric medication. If you compare the Republic of Ireland to the North, for example, a person in the North is more than twice as likely to be prescribed an antidepressant compared to the South, or the Republic, I should say. More than twice as likely to be prescribed a benzodiazepine or a sedative compared to the Republic as well. I mean, I do not believe that there are such increased rates of depression or anxiety disorders north of the border, just different practices. So the issue that you raise and that has been raised is a very, very real issue about how these things are decided. We know that medication, say like antidepressants or antipsychotic medication, can help some people significantly and even substantially. But and I go into this in the book and the evidence for this. However, we also know that medication is not enough. We are not just sort of chemical taking creatures. We are creatures in search of meaning, in search of understanding, in search of connection. And these are all aspects of well-being and healing that tablets simply don't provide. They are very helpful, but they're not enough on their own. And individual responses vary. It's much better to think about antidepressants or antipsychotics or things like this, these medicines, as tools that can be helpful for some people at certain times. A bit like different kinds of pain medication, where it can be helpful for some people at some times. And there's really no way of knowing, like if we have the same injury, Derek, it's possible one medicine will help me and a different one help you. That's just the way it goes. So there is a bit of trial and error involved, but we know that systematically the medications are helpful.
Yeah, and I point out that I take a couple of different types of medication, and they do help an awful lot. And lithium was one thing that was brought in to my treatment. It was about 2 or 3 years into my treatment. I was still not maybe feeling well, and I was on an antidepressant and Xanax and things, which I wasn't quite, but as soon as the lithium was kind of brought in, it did increase my my mood. But like you say, it's a lot. I'm doing a lot more than just that. Like I'm training, and I'm keeping doing the things I enjoy doing, and there's so many different things. It's not just medication. And I can't speak for people who think it's just that idea of throwing medication at it, but it rarely is. The people who I've spoken to, I mean, the medical professionals that I've spoken to would advise me to do other things. It wasn't just medication, that's it, and then off you go. I wanted to ask you about lithium, because it's obviously treatment that I've used, but the introduction to treatment, it was to do with mania in the first place, wasn't it?
Yeah. I mean, lithium, and I go into lithium a little bit in the book, and John Cade's discovery of its usefulness. And like a lot of things, it was discovered almost by accident, but then tested and found to be helpful. Now, why it is helpful, I could tell you 10 theories, but the only thing I can tell you with certainty is that for some people, there is a very good chance it will be helpful. Heaven alone knows why, but that shouldn't necessarily detain us too much if it does indeed help people. So it was introduced for mania, but that is elation, or if you like, the elevated mood sometimes seen in bipolar disorder. But it does seem to have a more generally stabilizing effect without being sedating for most people. So it tends to prevent big mood swings in bipolar disorder or manic depression. But it can also be helpful if someone is depressed, and it can help with an antidepressant medicine to do its job. And these are all just things that have been discovered. We know that they're true. We don't quite know why they're true, but we do know that they are true. And lithium is one of the great survivors in psychiatry, which is quite a fickle field in some ways, but lithium has stood the test of time. In a way, it's a bit annoying because we don't know why it works. And I wish I could explain why it works. I just have to see, this is again, Derek, back to the unanswered questions. You know, I'm absolutely sort of tickled or intrigued by the idea that the evidence is lithium works, and we really don't know why, and that just blows my mind sometimes.
Yeah, I'm just glad it does, to be honest. So, did you enjoy the traveling side, because you've discovered so much on your journeys?
Yeah, so in the book, In Search of Madness, like literally in search, I headed off to India to look at some of their huge big mental hospitals, which are still functioning there. Headed off to Germany, where there was a big Nazi program in and around the Second World War time, which victimized and murdered, killed people with mental illness. Went to London, to Bedlam, one of the earliest psychiatric institutions, and a marvelous mental hospital in Ghent, in Antwerp, in Ghent, which has been changed to a museum. So I just absolutely love this, because I love seeing the commonalities across countries and then the differences. And I guess I also need to be reassured sometimes that mental illness or psychological suffering or whatever it's strangely constant across cultures, across countries. The accounts of this in ancient Indian texts are very similar to the accounts you might find in the Bible or in a case book from Grange Gorman in the 1800s, or in a patient's file today. You know, the constancy of the suffering is one of the things that gives psychiatry its core, its meaning, and, you know, reminds me that something important is being done.
I don't know if it's a fascination of mine, but I'm definitely someone that's interested in the number of treatments that were used over the years, and some of them perhaps more barbaric than others. Insulin therapy, it was I read about it somewhere, but not as you know, in maybe in depth as you went on it. Can you describe what insulin therapy was?
Yeah, so insulin therapy is a treatment that's no longer in use. It was used in the early 1900s, maybe the 1930s, 1940s. And at a time when the asylums were huge, there were like thousands of patients in them. And there was a lot of pressure to discharge people, to get people home, get them out of these institutions. So all kinds of ill-advised treatments were tried with undue enthusiasm. One of these was insulin therapy. You gave a person insulin, and insulin is a hormone that we all produce in our bodies, but you give them so much of this, they go into a coma for about 15 minutes twice a week. And you wake them out of the coma each time using glucose, which is kind of the opposite of insulin. So you give them glucose and they wake up after a 15-minute coma. And you do this twice a week in a psychiatric hospital for a few weeks. Now, this is no longer done, obviously, but it was done at the time for schizophrenia because of the idea that a shock, a bodily shock, like going into and coming out of a coma, was therapeutic. It wasn't. Worse again, it is very difficult to give the right amounts of insulin followed by the right amount of glucose twice a week. So there was huge variation in how this was done across hospitals. All the patients gained a lot of weight because that's one of the roles of insulin, is governing that. And our bodies are really subtle. Our bodies are really good at regulating these things. But then when we come along and start giving you loads of insulin and loads of glucose, we can't fine tune it. So this treatment, it didn't work. Everyone gained weight, and it had a death rate of maybe, well, it's very hard to say, maybe at least 5%, maybe more. So it had to be abandoned. And it was driven by a desire to empty the asylums, but it was disastrously misguided.
it's a frightening one, because like you said, the idea of putting someone into a coma, the idea of that is enough to send shivers down your spine. There, you mentioned an article you read about schizophrenia, and a number of years ago I read an article about lobotomies and the evolution, I guess, of the lobotomy. So that led me down the little, rabbit hole, and I bought the biography of Walter Freeman by Jack L. Hyatt, and you mentioned that in the book as well. The lobotomy is, people kind of know what the idea behind it, but it did change over time as well, didn't it?
It did. So lobotomy is basically a kind of brain surgery for severe mental illness. Now, the idea of surgery for severe mental illness is not in itself a ridiculous idea. You would think, okay, maybe that might work. There are problems from the get-go, though. Firstly, we don't really understand what's wrong with the brain in most mental illnesses, and you kind of need to know that before you start doing surgery. But in the 1930s, a Portuguese doctor, Moniz, started doing a brain operation, having decided that the connections between one side and the other side of the brain needed to be severed. And so they started doing this operation where they basically did surgery on the brain and cut some of the connections. This really took off in the United States, where a surgeon called Walter Freeman and his colleague, Dr. Watts, they were so worried about the size of institutions that they began doing this surgery left, right, and center, and did it on so many people without following them up over time, that it took years for it to be, the surgery evolved, but it took years for them to figure out that most people were harmed by this and not helped. A certain number of people became less agitated and therefore easier to manage in the institution, but this came at huge cost. And this was even worse than insulin coma therapy. The most famous example of this is Rosemary Kennedy, the sister of John F. Kennedy, the president. And Rosemary Kennedy appears to have had some kind of behavioral problems, not severe mental illness that anyone can identify, but her father consented to her having a lobotomy by Freeman and his colleagues, and it was just disastrous. She had the surgery in 1941. She became much, much worse as a result, was institutionalized and incontinent for the rest of her life, many, many decades in institutions before dying. And lobotomy is easily the biggest mistake in the history of psychiatry. And the mistake wasn't considering brain surgery. The mistake was not checking, did it work or did it not work? This is the failing. And that was the big learning point from lobotomy, something that was learned at huge cost to so many people.
Yeah, I think you gave the number, I might be wrong, was 3,500 that he did himself, him and his colleagues. And now I can't put the blame on you for this, Brennan, but I watched the lobotomy that you mentioned. It's on YouTube, actually, readily available. And I guess it's an educational video in a way, but there's a lot of things to it, but I'm not going to go into them in depth. There's certain bits that are very, very graphic, like, it's the idea of it, like almost like a horror film watching it. But there was certain moments then where I wasn't, there's a voiceover obviously going on. So they're working either side, kind of around the temple behind it. And there's a guy behind, one of the doctors behind, and he's just he's judging by his eye alone whether it's going straight through. And that, like, he's not an X-ray machine for one, but it's like you're saying, it was one of the biggest disasters. But I can kind of see just from that video why that might be the case, because it seemed, when you're messing with something so complex in a way that you're kind of guessing at certain parts, not totally, obviously they're trained professionals, but there's a little bit of guesswork going on there.
Yeah, there is. And, watching the surgery, it makes you wonder about the phrase, surgical precision that you hear when people say, in another context, he did that or she did that with surgical precision. Yeah. I always think, hold on a minute now. Surgery was not and is not always as precise as you might think. But certainly those videos you describe, they're videos that are freely available on YouTube and elsewhere of the lobotomy operations being performed. And as I recall, Derek, I do issue some kind of warning, caution that watching this is not for the faint of heart, and probably not to be done on your own, because it's very, it's very troubling. It's very troubling material to watch, and it's probably important it is available. It's important we remember it and understand it more and take learning points from it, but also with a degree of caution and watching out for your own psychological wellness.
For sure. And look, there's worse things on the internet than that. So you made another thing that was great. You mentioned One Flew Over the Cuckoo's Nest, and ECT is another thing that has developed over time, and it's still in use now in a much, I guess, a much safer way than it's shown in that film. I first came across it in that film. I hadn't seen it. I was quite young when I saw the film. A number of years later, I wanted to get it done. It's because I was kind of at a dead end where I thought there's nothing else that I can do. I asked my my psychiatrist, could it happen? And he said I wasn't the right candidate. And you talk about like memory being affected and things. And I understand it now why he did it. But at the time, I guess I was fuming. But what are your thoughts on the presentation of it in One Flew Over the Cuckoo's Nest?
Well, One Flew Over the Cuckoo's Nest is one of these big iconic films, and when I talk to classes of medical students, a large number of them have seen it, even though the movie came out in 1975. Now, at that time, ECT was not being given as shown in the film. It was right, as is the case today, being given less commonly and with anesthetic and to far fewer patients. But nonetheless, the depiction of ECT in the film is extremely vivid, very, very disturbing, a lot of violence. Now, ECT, or electroconvulsive therapy, is based on the idea, again, that a shock to the body is therapeutic. And it started in the 1940s when they tried to give people seizures, like convulsions or epileptic fits, using medication, but they eventually moved on to using electricity. Now, in recent years, it's been studied with enormous care, and it does appear that there is strong evidence ECT helps a small number of people with severe depression under very specific circumstances. Now, Derek, a bit like lithium, I find this very annoying because we don't know why or how ECT works. I can give you 10 theories, but we don't really know. But it is very clear that for a small number of carefully selected people, it does. So I'm not surprised your psychiatrist said, you just weren't the right candidate, because it's really tightly regulated. But I've prescribed ECT maybe 4 times in my 20 years working, and on 3 of those times it was extremely helpful for the person. One of the times it was neither here nor there. But so the depiction in One Flew Over the Cuckoo's Nest is very, very misleading as far as contemporary ECT is concerned, where it's now given with an anesthetic, and it's all very calm, and it's very regulated. It is densely regulated now. There are so many rules governing it that, for example, some hospitals don't do it at all, and they send anyone who needs it to another hospital where we can keep a team properly trained up, properly accredited, everything up to date, because the numbers are lower, but it is still needed, and it can be remarkably effective, but far fewer people and far less dramatic than One Flew Over the Cuckoo's Nest.
Yeah, every time I mention it afterwards that I wanted to get it done, and I mention it now, someone will say that's their idea of it is from One Flew Over the Cuckoo's Nest, and just seeing Jack Nicholson go through it and stuff like that. And I try and explain, well, that's not how they do it anymore. It's a lot different. But I'm guessing from what you've said about lithium and from ECT about you're kind of annoyed by not knowing, that's where your continued kind of search and, I suppose searching for a meaning for some of these things drives you on to write these books.
Yeah, absolutely. I mean, I'm intrigued by that. In a sense, I'm constantly a little bit bewildered that we have treatments that work. Yeah. I talk about the evidence for antipsychotic medication in the book, for example, and the big difference today is that we do follow people up. So I talk at some length about a research study that followed up 62,000 people who received antipsychotic medication and follows them up for 14 years. Now, the reason for this length of follow-up is to make sure we're not doing a lobotomy on it, or we're not doing an insulin coma on it, and we're not missing something really, really important. But, the studies show that for the antipsychotic medication, not only do they reduce symptoms, but they reduce the risk of someone dying. They reduce that risk by almost 50% over the following 14 years. So these are people with schizophrenia who tend to have an increased risk of death, mainly from heart disease and cancer. But we find that being on an antipsychotic medication, treating their mental illness, is associated with much lower chance of dying over the following 14 years. So that's the big difference. Even though we might not know quite why these treatments work, we are now following people up for 14 years, 20 years, and even longer to make sure we know what we're doing. So we're not claiming antipsychotics are a miracle cure, the way they claimed for lobotomy and stuff like that, and turned out to be so wrong. What we are saying is that there are significant benefits for many people, despite side effects or problems. And that's a big difference. We have a much more modest psychiatry, but a firmer, clearer one as a result of this kind of follow-up research.
Time magazine had a mental health edition. I think it was a couple of years ago now, maybe. And I found they talk about the newer treatments, such as like microdosing with LSD and ketamine seems to be talk of that, and whatever the ingredient for magic mushrooms is, I'm stumped.
Psilocybin.
That's what it is. I'm glad I didn't have to pronounce it. What's your take on those?
Yeah, I mean, there is a certain amount of evidence to support some of these, like psilocybin, for example. As you say, similar to magic mushrooms. There is a research study going on here in Trinity, and at the moment, looking at that. We're part of my colleagues are part of a much bigger study, and there is a small amount of evidence that it's helpful for some people. There is something called esketamine, which is a variant on ketamine, that is currently licensed for treatment in Ireland for treatment-resistant depression for certain people. But these agents, they always capture the headlines. I think it's because a certain generation of journalists out there think this new research, shall we say, legitimizes things they might have done earlier in their lives and proves that they were right after all. So that they don't really, but there is a role for these things. And I think it's great we're looking at them, even though we don't quite understand why they might work. There is some evidence that for some people, these substances have a role. And the first licensing has been for esketamine, as I said, a version of ketamine, but it's really controlled, really tight. So only people who've had 2 different treatments for depression that haven't worked well enough. The person still needs to be on an antidepressant medication as well as the esketamine. It's administered twice a week nasally, but only in a clinic setting. The person has to be monitored for an hour and a half afterwards, and they're not being monitored for psychedelic experiences or going on trips. They're being monitored for a slight increase in blood pressure. So it's very tame, it's very controlled, very limited, but there does seem to be a role.
Yeah, I was telling people after I read the articles on it, and everybody thought I was only having a bit of crack or whatever. Like, they weren't quite sure that I was being, but I kept making the point microdosing. I kept saying the microdosing thing. But so, Brendan, what do you think we need to do to improve the situation going forward with regards to mental health?
Well, I mean, there's a few things in the book. I finished with what I call a manifesto, but one of the big issues is there's been a lot of media discussion about mental health in the past few years, and this has helped so many people. It's helped people remain well. It's helped people who have difficulties to reach out, to feel understood, not to feel so different. But we do need to acknowledge that at the other end of the spectrum, in a sense, there are very severe mental conditions, illnesses, is what psychiatrists will call them, things like schizophrenia and bipolar disorder and severe depression that really can be life-threatening. So while, and I talk in the book about the value of running and mindfulness and broccoli, I think these are all good things and they help us a lot of the time, but there are points in people's lives when sometimes they're move a bit beyond that and they need a little bit more, maybe to see a psychotherapist or to see their GP, or ultimately to come and see a psychiatrist like myself and my colleagues who see a lot of people in these severe states of distress. So I think a recognition about the existence of severe mental illness that is beyond the reach of those really good things, jogging, mindfulness, and broccoli. I love them all except the broccoli. Yeah. But we do need to acknowledge there is a profound suffering and risk to life that can come.
I obviously read the manifesto as well, and we talk, like, I think a lot of the things we talk about you hear in the press and the different, like, it's Mental Health Awareness Week this week when we're recording this, and we talk, oh, it's good to talk, people need to talk and stuff, but I think another side of the thing is for people to listen as well, because that's as important as someone talking, and I that's not to say that people aren't listening, but I mean properly sit down and listen to someone go through it, because I think sometimes I'm not going to have a go at phones or anything like that, but I think sometimes we're not quite in the room at times, and I think what somebody needs, even if it's just they're having a really tough week or whatever it might be, to sit down and listen to that person talk and take it in, and good advice is great too, but I think the whole thing of someone listening has been very helpful to me. When I know someone's listening to me, I think it's a huge deal. You went on the Tommy Tiernan Show. How was that experience for you?
Right. Well, that was great. This was back, I think it was towards the start of the Tommy Tiernan Show. And I was very busy at the time, and I agreed to all kinds of things without fully knowing what they are. Today is another example. I just agreed to that and went along. And I hadn't quite understood what was involved at the time, that Tommy didn't know anything about his guest and therefore could talk about anything. In the end, happily, we ended up talking about mental health and mental illness, and I think that was useful. And Tommy Tiernan really does listen, and he has to listen because he knows nothing about the guest. Like, he genuinely doesn't, not a rashers until you walk out. So it's really important that he listen. And your point about listening is so important and so well taken. And there is this concept called containment, which is it's really psychological or emotional containment, so that if someone comes to you, say, Derek, and they're upset and they're having really distressing thoughts that are overwhelming them, maybe hearing voices, maybe believing people are poisoning them, maybe thoughts about harming themselves or even ending their life, they want to talk about it. And if you're able to listen calmly, and as you say, properly listen calmly, and not be overwhelmed, that is an incredibly important thing. If you like, you're containing them. By listening, you're demonstrating that the experience that's overwhelming the person isn't overwhelming you. You can hear it, you can take it in and not be totally freaked out by it. You can contain it. You're bigger than it. So even if you don't give any advice, and sometimes it's best not to, you've done the most important thing by taking it in and visibly containing, not being overwhelmed by the thought or the feeling or the worry that is overwhelming the person that has come to you. And that's containment. And it is the most important thing. It is an incredibly powerful thing to do. We are so powerful when we talk to each other. And that's so important. It is far better than simplistic pieces of advice. So, things like everything is okay. Even saying that, what that sounds like is you're not listening. It's because, of course, everything isn't okay. If I come to you, Derek, in a state of huge distress, and you tell me, don't worry, everything's okay, I hear that as you're not listening to me. I've just told you everything isn't okay. It clearly isn't. So sometimes less advice is better, and more proper, deeper, longer listening is hugely therapeutic.
For sure. The reason I brought up the Tommy Tiernan Show, though, okay, because I thought this was a very important answer that you gave on the show. Tommy Tiernan was asking about, the suicide statistics for a certain age group, and he asked you why that is, and you said, I don't know. And I think what was powerful for me when I watched it was the fact that a lot of people maybe in your position, Brendan, would try. It's an ego thing, I guess, sometimes, where people want to solve it, right there and then. But how could you know the answer to the question? But you obviously went on. You didn't say, I don't know on that. But that there's something very powerful about that. And I guess it was something that happened on the spot, because you're not expecting those questions from him.
Absolutely. Yeah, no, it's a very the way the program is structured, there's nowhere to hide. There's nothing you can do. So it is important to be honest. And yeah, the I don't know answer is it's when it's truthful, it's truthful. And in relation to suicide, of course, I don't know is such an answer because, clearly I haven't died by suicide, nor have I attempted any form of self-harm, nor have I ever come within any distance of that at all. So we need to be ready to say, I don't know, and to learn and to listen. And we really don't know about suicide because it's not terribly widely known that the number of people dying by suicide around the world is falling very rapidly. I mean, the rate and number of deaths from suicide fell by a third between 1990 and 2016. Like, that is a huge shift, a huge decline in suicide globally. And I used to say this is the biggest public health development of our lifetimes. Then COVID came along, and COVID is now the biggest public health development of our lifetimes. But the biggest positive public health development of our lifetime is the decline in suicide. And even during COVID in the United States, suicide fell by 6%. So we really don't understand an enormous amount about suicide, and we need to try harder. The fall in suicide globally is good, but it's not enough. I'm not saying it isn't a problem. It clearly still is. Even one suicide is one too many. But the global decline tells us that positive change is possible. Nothing is written in the stars. We can get this number down more.
And I found that those statistics off you, and it wasn't, reported when those kind of, like you say, it's still not happy news, but it's better, and it's getting better. Could you tell us, and this is shamefully, I did not read this book yet, but I will. Could you tell us a bit about The Science of Happiness?
Well, The Science of Happiness is a book. Well, it's a book I wrote. It came out a couple of years ago from Gill, and it's about the study of happiness. And even that very sentence, the study of happiness, raises any number of questions. How can you possibly study happiness? Like, I might have been happy when I was eating a biscuit, or maybe three biscuits before we recorded this podcast. And now I might be unhappy because maybe my phone has been ringing, and it changes so quick. How can we even study such a thing? So the book is looking at the research about happiness. The other big trigger for it was that research around the world shows that the age of greatest unhappiness is 48, and that was exactly my age when I wrote the book. I was in the unhappiest part of the human life cycle, and I wanted to know why this was. So it looks at the happiness research, but the book then goes on with some strategies about how to be happy and how to have better mental well-being in our lives.
And this is a very simplistic question, but do you think it is attainable for everyone?
Well, I think we can be happier in our lives, and it's useful, though. It is useful to think a little bit about this, and to think of our lives in terms of two kinds of happiness. There is pleasure, enjoyment in the moment, and then on the other hand, there is contentment. There is having a job, having a mortgage, paying it off, building up a pension. Okay, these things bring different kinds of happiness, and in all of our lives, we have a mix. Now, as we move through life, we tend to move from one end a bit to another. We start with the pleasure end of things. We drift towards the contentment end of things. But it's useful to consider both and make sure we have both. So, yeah, I think it is attainable. One of the best ways, though, to become happy is to stop trying and to focus on something else. So, to focus on absorption, focus on like, most of us are at our happiest when we're doing something we absolutely love, like doing the gardening. For a lot of people, when they forget about time, they might be doing it for an hour, and suddenly they've been doing it for 3 hours. It just melts away. And that absorption, maybe that's how we attain happiness.
For sure. Is there a lot of interest in people who want to become psychiatrists?
Yes, yeah, there is. And it's one of the growing branches of medicine.
Okay.
A lot of interesting things going on, a lot of interesting science going on, interesting therapies being developed, interesting changes. It's a very, very contested field. It's really, really, really interesting. And it's just very, very rewarding. The amount of suffering involved and that we see in people and their families is huge. But they tend to really, really appreciate time, attention, and the various treatments.
That's great. So the hardest question, what do you do in your spare time?
What do I do in my spare time? Well, prior to the pandemic, I was always to be found in the cinema. I would go to movies. I live in the center of Dublin. I would go to the Irish Film Centre and watch 3 movies. I'd spend the whole day in there. A nice sunny day means I could walk to the cinema.
Beautiful. Come on. So tell because when people bring this up, Brandon, I have to ask the question: what is your favorite film of all time?
Oh my. Well, that is an interesting question. I do have an answer.
Do you?
Yeah, it pops readily to mind.
Okay.
Yeah. It's a film. It's an obscure art house type film that I watched. Maybe it's because I saw it at a certain point in my life rather than the film itself. That's impossible to untangle. The movie is called The Double Life of Veronique.
Oh,
it's
yeah, no.
A French-Polish film by Krzysztof Kieślowski.
I think so.
The director. Beautiful music by Zbigniew Preisner. And it's such a dreamy, beautiful movie. I rewatched it, perhaps foolishly. I mean, I first saw it when I was much younger, and I rewatched it several years ago, and I still loved it.
I can wholly, and I won't go through this story again because I've said it a number of times. My favorite is 12 Angry Men, but it's a great film, but it's a lot to do with when I saw it, the conditions I saw it in, and that kind of thing. So when you go back to it outside of those conditions and it's still great, I think that's that's the best thing. But and that's happiness, like we were saying. But do you have a next book on the horizon, or are we taking a little break for a while?
Well, there are various projects on the horizon. I'm clearly kind of fudging around and not answering that question, Derek. You don't need to point that out to me. Yeah, no, I mean, life is very full with writing projects and papers and research and bits and pieces. For the moment, I guess the focus is on the current one, In Search of Madness. But if another one appears, we can talk about it then.
That sounds very vague, but I like it. Brendan, it's been a genuine pleasure, and I love chatting to you. I will reveal now. I was going to reveal it at the start, but I was worried that I'd jinx it. But this is the most research I put into an interview so far. So I was a bit nervous, but I feel really good now at how well it's gone. So thank you very much for that.
Well, listen, Derek, I really do appreciate the thought you've put into this. You clearly have read the books, and it's kind of a privilege for me whenever someone reads a book, because it takes a few hours and a bit of application, a bit of thought on your part, and it does make me feel very humbled and privileged to be able to write these things, and I hope that some benefit comes of them. So I really do appreciate your time and your attention.
No problem. I was in Easton's the other day in Athlone here, and I saw your book there. So if anybody's listening to this and wants to buy it, pop down to Easton. Will you stay with me for 1 second, Brendan? I'll close it out. I'll get a quick photo and we'll go on our way. Is that all right?
Perfect.
Okay. Thank you very much to John for the tech side of things. I always thank my mum, my dad, granddad, Ger and Calvin. Subscribe to our YouTube channel if you wouldn't mind. We're on Instagram, Facebook, Twitter, all the usual places on the podcast platforms, Spotify, Apple, Anchor, etc. Obviously, thanks very much for tuning in, people. And once again, Brendan, thank you very much.
Thank you.
Right, people, we'll all see you next week in the same place. Take care. Bye.